I am Dr. Bhavani Rao. I am Professor of Surgery. This video is meant for MBBS students. If you are MBBS students, please go on. If you are not, pass on this video who is pursuing MBBS. The Medical Council of India has been replaced with NMC or National Medical Council. The National Medical Council, it has changed certain guidelines for teaching the medical students as well as evaluating them. This page is taken from NMC website and this is based on curriculum based medical education. Here the syllabi for thyroid diseases is mentioned. It also mentions whether this is core or non-core and also the knowledge domain of the student, whether he should know or know how, show or show how. The NMC website also gives guidelines to the examiners how to set the paper for evaluating the MBBS student. This can be long answer question, short answer question or multiple choice questions. And while structuring the long answer questions, to each part of the question, how many marks should be awarded. As an example of long answer question in NMC pattern, we will discuss a case of multinodular goitre. In the process of answering the question, we will also learn the disease process of multinodular goitre, and in discussing differential diagnosis, we will also learn briefly about other conditions those affect the thyroid. Here is the question on NMC pattern. A 45-year-old woman presents to the clinic with a complaint of swelling in the neck. She noticed the swelling growing over the past year. On examination, you find multiple nodules in her thyroid gland. She has no other symptoms. What is your provisional diagnosis? That carries 2 marks. So here is the NMC pattern of questioning. On the topic, multiple questions are given and the marks allotment is also given there. What is your provisional diagnosis? Carries 2 marks. What other conditions need to be considered in this case? 3 marks. Enumerate the investigations that you will order and their likely findings in each of the diagnoses that you considered. 3 marks. Explain the physical findings in the light of underlying pathophysiology. 2 marks. Obviously, he didn't ask for the management part, so we are not going to discuss that part in detail. The provisional diagnosis for this patient is multinodular goitre. This is based on patient's age. She is 45-year-old woman. The gradual increase in size of the neck swelling. She has noticed the swelling growing over the past year. And the presence of multiple nodules in the thyroid gland. So you find multiple nodules in the thyroid gland. Any enlargement of thyroid is goitre and the provisional diagnosis for this patient is multinodular goitre. What other conditions need to be considered in this case? This carries 3 marks. One way to go through the differential diagnosis is to scan through the classification of the thyroid swellings. The more important of these conditions are simple non-toxic goiter, toxic goiter, neoplastic swellings, thyroiditis and thyroid cyst. Diffuse non-toxic goiter gives rise to uniform diffuse swelling. It doesn't give rise to multiple nodules. So we don't have to write in the answer sheet. But just to recapitulate our memory, I am just passing through the etiology of simple non-toxic goiter. The simple diffuse non-toxic hyperplastic goiter can be physiological. During puberty and pregnancy, there are increased demands for thyroxine as well as iodine. So there is enlargement of the goiter for meeting the increased demands. This can also occur due to primary iodine deficiency as in endemic areas. Secondary iodine deficiency can also occur by eating lots of brassica family vegetables such as cabbage, cauliflower, rape, soybean, etc. Excessive fluoride in the water can also give rise to iodine deficiency, and certain drugs like PAS, lithium phenylbutazone, thiocyanate, potassium perchlorate and antithyroid drugs, they can give rise to diffuse simple non-toxic goiter. Then there is colloid goiter. This is end stage of the diffuse simple non-toxic goiter where the follicles are filled with colloid. Then we have nodular goiter. So this is the present case. Solitary toxic nodule also should be discussed. Why solitary non-toxic goiter should be discussed? Solitary non-toxic goiter, clinically, though it is solitary or discrete, there can be multiple nodules by ultrasound examination. So solitary non-toxic goiter, solitary non-toxic nodule will also come into the differential diagnosis. Toxic goiter, whether it is multinodular or diffuse, they won't come into our differential diagnosis because this patient doesn't have any symptoms. Then we have neoplastic conditions. They can be benign or malignant. Benign can be follicular adenoma or Hurthle cell variant can also occur. Benign papillary adenoma doesn't exist in thyroid. The carcinoma variants, papillary, follicular, are common and they can give rise to nodules. And medullary anaplastic varieties of carcinomas are rare, and rare diagnoses are rarely correct. Lymphoma will also give rise to diffuse swelling. Thyroiditis, the Hashimoto's variety, this can give rise to multiple nodules sometimes. The other types of thyroiditis like De Quervain's radials, they are rare. Going through the classification of goiter will cover all the conditions. Those come under differential diagnosis for multinodular goiter or any other goiter. So the goiter can be classified as non-toxic goiter, toxic goiter and special conditions. The non-toxic goiter can be diffuse hyperplastic goiter, or it can be multinodular goiter. It can be solitary nodule or it can be recurrent. The diffuse hyperplastic goiter can be physiological, endemic, and secondary iodine deficiency. The pathophysiology we will discuss about the multinodular goiter in next few slides. Solitary thyroid nodule. Clinically, if you expose a solitary nodule thyroid patient to radiological examination, in half of the cases, you will also find some more nodules. Those are visible ultrasonologically. In a way, clinically solitary nodule can also be multinodular. Then we have toxic varieties of diffuse hyperplastic goiter, where we call this as Graves' disease, and toxic multinodular goiter, which is known as Plummer's disease. Then if it is toxic, it is toxic adenoma. Then we have special conditions like malignant ones or autoimmune ones. The malignant ones can be benign or malignant. Benign can be follicular adenoma. Papillary adenoma doesn't exist. The malignant varieties are papillary or follicular. These are more common. The anaplastic and medullary are rare, and lymphoma is also rare, and this also gives rise to diffuse swelling. Then we have autoimmune thyroiditis. The Hashimoto's thyroiditis is more common. De Quervain and Riedl's they are rare. The Hashimoto's thyroiditis, they can give rise to multinodular goiter. So out of these things, the multinodular goiter gives rise to multiple nodules. The toxic variety of multiple nodules also gives rise to that. And the Hashimoto's thyroiditis can also give rise to multiple nodules, and some malignancies can also give rise to multiple nodules. In addition, you have thyroid cysts. Multiple thyroid cysts also can give rise to multiple nodules. Diffuse parenchymatous goiter or diffuse parenchymatous hyperplastic goiter. It is uniform enlargement of the thyroid gland, and it feels comparatively soft. There won't be any nodules. Colloid goiter is the end stage of the diffuse parenchymatous goiter. The whole gland becomes enlarged. It is soft and elastic. There won't be any nodules. When there is single nodule in the thyroid, then it is solitary nodular goiter. In half of the cases of solitary nodule goiter, when radiologically examined, the other part of the gland contains multiple nodules. When there are multiple nodules, the treatment is that of multinodular goiter. Multinodular goiter, as the name implies, it has multiple nodular surface. Why surface is like that? If you cut open the multinodular goiter, it reveals nodules with hemorrhages and necrotic areas. In between, there will be normal tissue with active follicles. In endemic areas, this appears between 20 and 30 years. In sporadic cases, it is between 30 to 40 years. Nodular goiter, multinodular goiter is more common in females, and it is 6 times more common in females than in males. It is slowly enlarging painless lump, as it is in the question. If there is any sudden enlargement, it causes pain because of the hemorrhage into the inactive nodules. There can be pressure symptoms. Pressure on the trachea causes dyspnea, and it may impede the venous return, causing the engorged neck veins. And pressure on the esophagus cause dysphasia, and there can be stridor also. In 25% of cases, secondary thyrotoxicosis may ensue. These patients also, over a period of time, when the patient reaches 6th or 7th decade, they may go into myxedema. Primary toxic goiter or Graves' disease or exophthalmic goiter with prominent eye signs, it doesn't come onto our differential diagnosis. Secondary toxic goiter. It is nothing but toxicity superimposed on multinodular goiter. In the question, it is clearly stated that there are no symptoms. Hence, as per the question, this is not a case of multinodular toxic goiter. Papillary carcinoma sometimes gives us a challenging scenario because this is also more common in females. This also grows very slowly. The lump is not tender. Papillary carcinoma, it spreads to the regional lymph nodes early, and they can be confused as a nodule that is in the thyroid itself. And because of multiple foci of origin and lymphatic spread within the thyroid gland, there can be multiple nodules in the thyroid gland itself. So this can give rise to diagnostic challenge. Follicular carcinoma also can give rise to diagnostic dilemma. This also occurs more common in females. This is also slow growing, but if it already spreads to the bone, then there can be bony pain. If that is the case, we can make a confident diagnosis of follicular carcinoma and we can exclude the multinodular goiter. Although females are more affected in anaplastic carcinoma also, this is big lump with hard, tender, irregular and diffuse margins. There can be dyspnea, hoarseness, pain into the ear, all these complaints. So this doesn't really come into the differential diagnosis of multinodular goiter. Autoimmune thyroiditis or Hashimoto's disease, usually it presents as a diffuse enlargement of the thyroid. It usually involves one lobe, sometimes both lobes, but it can also sometimes give rise to multiple nodules. Because this is autoimmune disease, there can be associated features like rheumatoid arthritis, disseminated lupus, hemolytic anemia, purpura, myasthenia gravis, and pernicious anemia. So the diagnosis is confirmed by the autoimmune antibodies like TPO and antimicrosomal antibodies. The investigations that should be ordered should include first the ultrasound neck. This helps determine the size and number of the nodules, whether they are cystic or solid. And it also helps in guiding the FNEAC. Next investigation of choice is fine needle aspiration cytology. This involves passing a small needle and aspirating a few cells and examining under microscope. This can help differentiate a benign from the malignant nodule. Then thyroid function tests, they are T3, T4 and TSH. In multinodular goiter, all these hormones, they are normal. Whereas in case of thyroiditis like Hashimoto's thyroiditis, in hyperthyroid phase, there will be hyperthyroidism. In case of thyroid cancer, the thyroid function tests are usually, they are normal. In thyroiditis, the antimicrosomal and antithyroglobulin antibodies are raised, as we discussed already. How do you explain physical findings in the light of underlying pathophysiology? The pathophysiology, First, there is iodine deficiency. Initially, it causes the hypertrophy of the thyroid. Then, it may lead to hyperplasia. Over a period of time, a few areas of the thyroid, they become hyperactive. And these clones of cells, because of mutagenicity, they form nodules in the later stage. And in between the nodules, the thyroid tissue is normal. Into these nodules, there can be hemorrhage. Because of these features, the nodules, they become firm to hard in consistency. That's how the multinodular goiter occurs. Thank you for patient listening. If you have any comments to make, please do. Thank you very much.